Today's presenters are truly experts in the field of respiratory muscle weakness. We have Dr. Nina Bausek, a graduate of the University of Vienna. She developed her scientific and leadership skills doing research and teaching at the University of Oxford and the University of Sheffield in the UK. She excels as a biologist and geneticist and has been granted funding from cancer research in the UK as well. Her findings have been published in international journals, and she now works in the areas of fertility, immunology, and oncology as a researcher. She serves as chief scientist for PN Medical. And Dr. Sigfredo Aldarondo graduated from the University of Puerto Rico School of Medicine and has been practicing pulmonology for the last 34 years. He also served our country as Lieutenant Colonel in the United States Army Reserves Medical Corps. He is recognized as one of the top physicians in his field and is an associate professor at the University of Central Florida School of Medicine. He currently practices out of Winter Park, Florida, and is the medical director of respiratory care for Advent Health. Dr. Aldarondo serves as PN Medical's chief medical officer. And my name is Wendy Underwood, and I'll be your host today. I'm a CODA, RAC certified, and certified dementia care specialist. I've been an OT assistant for over 18 years working as rehab director in various cardiopulmonary settings. And I'm excited to be here and learn and share with you today. Let's start with today's objectives. Upon completion of this webinar, participants will understand seeing the heart and lungs as one system matters, discuss an underutilized therapy that is a low-cost, high-impact foundational element to patient success, respiratory muscle weakness, identify diagnoses and associated treatments with respiratory muscle weakness, learn an easy treatment protocol to combat respiratory muscle weakness with respiratory muscle training, and define the actual definition of respiratory muscle training. See a demonstration of the first device of its kind used for respiratory muscle training, the breather, and take away new protocols and research you can utilize today. We'll also take time for questions and answers. Now let's hear from our experts. Dr. Aldarondo, take it away.
As many of you know, the purpose of respiration is to maintain aerobic metabolism, or the so-called fire of life. Oxygen intake and CO2 excretion require a functioning bellows systems, or a ventilatory pump, which is coupled with another very important pump, the cardiac pump. The cardiac pump is responsible for tissue oxygen delivery, sustaining aerobic metabolism, while allowing for CO2 excretion. This is a nicely coordinated dance between these two pumps, the ventilatory pump on one end and the cardiac pump on the other. Now, as you would suspect, the focus of our discussion today is the ventilatory pump. This sophisticated bellows system requires the activation of respiratory muscles to drive it. This presentation addresses in more detail the relevance of respiratory muscle function, the recognition of respiratory muscle dysfunction, its clinical relevance, and the avenues for treatment. If it wasn't because we have avenues for treatment, we'd not be here talking to you today. So maybe Dr. Bausek has an additional comments. Nina, you have anything to add?
Yes, I do. What is interesting here and really shows that these two pumps are indeed one system is the evidence that strengthening one side of the system benefits the other components. So people experiencing heart failure, for example, often have severe respiratory symptoms, mainly dyspnea, and they contribute to exercise intolerance and to the burden of disease. And that is because an impaired cardiac system is associated with an impaired respiratory system. And evidence shows here that strengthening the respiratory system not only improves the respiratory symptoms, but also has a direct effect on the underlying cardiac issues. And a very nice study by Priscilla Mello and others has shown that strengthening the respiratory muscles leads to improved autonomic control of the heart by decreasing the muscle sympathetic nerve activity and by increasing vascular compliance, and thereby decreasing the cardiac work. And this shows that the cardiopulmonary system is not only tightly linked during disease, but also during recovery from and management of heart failure. And that is a great plus, because the respiratory system is quite amenable to rehabilitation and to strengthening, and is easily reconcilable with cardiac rehab.
Fascinating. Thank you, Dr. Bausek. Now, as we stated, an integral component of respiration is ventilation, and this is the subject of our discussion today. And for ventilation to occur, we need our own bellow system, which is comprised of a rib cage, as you see in the illustration, and of muscles that are responsible to distending that rib cage and shift its position, and doing so, increase its capacity, lowering intrathoracic pressures and therefore maintaining airflow. Now, these are the respiratory muscles, and the main muscles for inspiration are the diaphragm, of course, and the external intercostals, as you may see on that illustration. Now, as you also know, the ventilatory process is comprised of two phases, inspiration and expiration. Inspiration is that, as under normal circumstances, the only one that is an active process that requires muscle activation, because the expiratory process is passive and only happens because of stored energy and the recoil of the rib cage and so forth. So only with increased exercise level, peak exercise, or under some disease states, is that the expiratory process then becomes more active. We recruit the expiratory muscles, and that clinically is translated into the manifestation of dyspnea as the patient experiences. Now, in many disease states, most commonly observed in COPD patients, the changes in the geometry of the rib cage and hyperinflation, the diaphragm is then at a mechanical disadvantage, and making it less effective, leading to increased work of breathing, compounded by increased airflow limitation, and in some patients, the onset of pulmonary cachexia with compromises respiratory muscle function even further, basically leading to a perfect storm. And this results in a vicious cycle of progressive respiratory muscle dysfunction, dyspnea, and ultimately respiratory failure. Nina, you may want to add a bit more comments on the diaphragmatic function, which is relevant to our discussion.
Yes, I would really like to add a few more thoughts on the diaphragm here. As you said, the diaphragm is, of course, the main breathing muscle, but that's not its only function. It also serves important other mechanical functions. Due to its location and positioning in the body, a strong diaphragm can also support balance and posture control. The diaphragm sits under the rib cage, as you can nicely see on the graphic that we have here. It sits under the lung and under the rib cage, separating the thoracic cavity from the abdominal cavity, and it attaches to the spine and the dorsal muscles in the back, as well as ventrally to the abdominals. And what evidence has shown here, that strengthening the diaphragm improves posture control and even reduces lower back pain. And it does that by stabilizing the proprioceptive use of the ankles and thereby stabilizing the entire core. There's a very recent study that came from the research group around Alison McConnell in the UK. And they have shown that a stronger diaphragm improves balance and may reduce the fall risk in elderly people. And that is, of course, a really significant finding, as falls and their consequences in older people are a major cause of morbidity and mortality.
I really like how you all have already added some good takeaways, like the two pumps are one system, and we should look at it as a nicely coordinated dance between them. I also love the research you just talked about related to the diaphragm strength and the associated fall risk. Very important info, and we just got started.
That's true, Wendy. So let's talk a bit more about respiratory muscle weakness itself. When we talk about respiratory muscle weakness, we have to touch on the specification of it. So respiratory muscle weakness is defined as having a maximum inspiratory pressure, or MIP, of less than 70% of the predicted value. Now, how do you measure your MIP? MIP is determined by exhaling to residual volume, followed by a maximum inspiratory effort. And that is then repeated 3 times, and the best of these attempts is considered the maximum inspiratory pressure. The maximum expiratory pressure, or MEP, can be measured likewise by maximum inspiration to total lung capacity and then forceful exhalation. Now, if respiratory muscle weakness is present, the typical symptoms include dyspnea, reduced exercise tolerance, and reduced health-related quality of life, which of course greatly contributes to the burden of disease. The causes of respiratory muscle weakness include respiratory muscle atrophy and/or respiratory muscle impairment due to hyperinflation, due to increased work of breathing, cachexia, or maybe following mechanical ventilation. In addition, neuromuscular dysfunction may also impair the activation and the recruitment of the respiratory muscle system, and again leading to respiratory muscle weakness. The consequences of respiratory muscle weakness include increased risk of exacerbations, hospital admissions with associated prolongation of length of stay and higher readmission rates, dysphagia and/or silent aspiration, and an associated increased risk of aspiration-associated pneumonia. And as mentioned before, reduced health-related quality of life.
I just heard 2 very popular buzzwords, the length of stay and risk of rehospitalization. Many in our healthcare field are looking for ways to improve outcomes in both of these areas. And respiratory muscle training may not be something they've thought of.
That's true, Wendy. And that may be a result of the widespread under-recognition and under-treatment of respiratory muscle weakness. Because the prevalence of respiratory muscle weakness is really high. And as this fact may be severely underappreciated, we just like to give you a few numbers here to raise the awareness really to the magnitude of the problem. For example, respiratory muscle weakness is present in up to 50% of chronic heart failure patients and in up to 76% of acute heart failure patients. Also, in COPD patients, about 50% of them suffer from respiratory muscle weakness, while in institutionalized elderly, the number may even be closer to 100%. And that's predominantly caused by the general muscle atrophy progressing during aging, as well as sarcopenia, if that is present. What has also been shown that 69% of patients leaving the ICU have been found to have respiratory muscle weakness. And that is in great part caused by mechanical ventilation, because after 6 days of mechanical ventilation, the respiratory muscle strength is reduced by 30%. So these numbers should just give you a brief overview of how prevalent respiratory muscle weakness really is.
So it sounds like you're saying respiratory muscle weakness impacts so many areas, but the good news is there's something we can do about it and impact our patient outcomes.
Yep, that is true, Wendy. And the question is, what really is the appropriate treatment of respiratory muscle weakness? Now, the typical interventions such as pharmacologicals, PEP, OPEP, PUP, and incentive spirometry, they don't really solve the problem of respiratory muscle weakness, because oxygen you can give that lasts for minutes. Bronchodilators may last for hours. And this is where the role of respiratory muscle training becomes apparent, because tackling respiratory muscle weakness through evidence-based respiratory muscle training is the only intervention that makes a long-term difference. Because what respiratory muscle training really does is to train the respiratory muscles just like you would train any peripheral muscle, by adding resistance. And this puts a workload on the muscle, which leads to an increase in muscle mass, muscle power output, and therefore an improvement in muscle function. When doing respiratory muscle training using the breather, that's the device that we work with, and we will talk about this in more detail in a minute, both the inspiratory and the expiratory muscles are worked against resistance. This leads to a strengthening of the inspiratory muscles, which include, of course, first and foremost, the diaphragm that we talked about already, which is the main breathing muscle, as well as the external intercostals and the accessory muscles. It also strengthens the expiratory muscles, including the internal intercostals and the abdominals, as well as the muscles of deglutition and phonation. So strengthening both the inspiratory and the expiratory muscle groups is an important and often neglected aspect of respiratory muscle training. It is, however, a very important aspect, as respiratory muscle weakness usually affects both muscle groups as well. COPD patients, for example, especially at the advanced stages, they often have severely reduced expiratory muscle strength in addition to their weakened inspiratory muscles. And that becomes apparent by the high prevalence of dysphagia in these patients. Now, while strengthening the inspiratory muscles help with the dyspnea and the exercise tolerance in these patients, expiratory muscle training is necessary to improve swallow function and pulmonary hygiene. So ideally, respiratory muscle training should work on both components of the breath cycle, the inspiratory and the expiratory phase. So clinically, what does respiratory muscle training translate into? The physiological consequences of respiratory muscle training include improving respiratory muscle strength. So the respiratory effort and the work of breathing are decreased. And that reduces dyspnea and increases exercise tolerance, which in turn then contributes to improved therapy participation, cough efficiency, and pulmonary hygiene. Dr. Aldarondo will now introduce the typical applications of respiratory muscle training.
Thank you for those comments. And as a complement to what you just said, I'd like to emphasize a few issues here. It is very important to understand that respiratory muscle weakness is largely reversible. That's why we're talking about it. That's why respiratory muscle training is a clinically relevant tool. And as previously noted by Nina so well outlined a while ago, the landscape of respiratory muscle weakness is very broad. The common denominator being, regardless of the cause or scenario, is a weakened dysfunctional bellows system, impaired cough mechanism, and in the case of the upper airway, poor deglutition. And as shown in this slide, the benefits of respiratory muscle training will be made evident in different ways depending where you're looking at. And in many cases, as you would probably know by now or figure out, a lot of these actually coexist. So depending on what direction you may be looking at, is the benefits or the improvement in patients' function. Keep in mind that none of these are mutually exclusive, as I said, and as I said, they often coexist. So you may have a patient with dysphagia that also has congestive heart failure, and at the same time, by doing respiratory muscle training, you may improve deglutition, and I see the decrease in dyspnea, as Nina pointed out earlier, for diverse reasons with the patient with congestive heart failure, including the decrease in sympathomimetic activity from the fatigue respiratory muscles. Or the patient may have experienced diaphragmatic weakness, respiratory muscle weakness for being on passive mechanical ventilation, and inevitably these patients will have some degree of dysphagia as well. And the prevalence that we see of this issue is enormous in the hospital setting. So no matter what area you're looking at, keep in mind that you will see an improvement that may not be isolated, be followed or joined in other areas if you're looking for it. So the applications are diverse and the benefits are many. Let's talk about the context. We can look at this a little differently. We can break this down into respiratory, cardiac, neuromuscular, surgical, and perioperative complications, and those associated with the aging process, as the slide shows. So these range in severity from very mild to severe. They vary in onset, acute in its chronicity. But in almost every instance, the awareness of the presence of respiratory muscle weakness from the clinician will open the doors to a more proactive approach. And so the management of these clinical challenges at hand, for instance, will be enhanced. You will be able to address dyspnea in a debilitated patient more efficiently. More can be accomplished with coexistent or simultaneous physical or occupational therapy and improving mobility strategies. Or maybe glottic function may also be separately addressed, resulting in better phonation, deglutition, pulmonary toilet, in the patient who already has compromised diaphragm. So you can see how many of these things fall in place, and it's almost naive or ineffective to deal with one component of respiratory muscle dysfunction and not address the others that are so important or relevant as well. In the case of the aging patient population, it was pointed out earlier, the prevalence of dysphagia is very high, and this may be disproportionately present despite no much intrathoracic dysfunction or diaphragmatic fatigue itself being an issue, but rather upper airway component, and that itself is relevant to address because of the secondary consequences of ineffective cough and the risk for aspiration. So it is and resulting in the ever prevalent pneumonia. So Nina, you may want to follow up on this a bit.
Yeah, that is a very important point that you just made in the aging population. And that is really supported by evidence from a long-term study from the Netherlands that has just come out. And they looked at decreased physical function and its impact on mortality in elderly people. So what the researchers found is that impaired lung function is associated with an increased risk of mortality. So even after assessment of a range of different parameters, the peak flow was identified as one of the strongest predictors of an increased risk of mortality. And the authors of the study speculated that during aging, physiological and structural changes lead to more rigid and less expansible respiratory systems with the declined strength of the diaphragm, compliance of the lungs, and inspiratory and expiratory intercostal muscle capacity. Small changes might cause older people to be less physically active, which may have a high impact on physical fitness. So while peak flow is, of course, not a direct measurement of respiratory muscle strength, a study that we conducted at PN Medical in collaboration with a national home health company found that strengthening of the respiratory muscles over a period of 4 weeks led to a significant increase of 92% of peak expiratory flow in home health patients. And that implies that the performance status can be improved by respiratory muscle training. And in line with what the Dutch study found, that I just stated, that this may actually decrease the risk of mortality. So the device that we are working with, that we use for RMT, is the breather. And the breather is a resistive respiratory muscle training device, which trains both the inspiratory and the expiratory muscle groups, thereby strengthening the entire respiratory system. Importantly, the training intensities for inspiratory and expiratory muscles can be set independently. This allows to really work each muscle group towards the specific training target. Our host, Wendy, has used the breather in her practice as an OT, so we'd like to hear her story.
Yes, thank you. As an OT assistant, I once was directing an entire county in Florida for home health. And what I found, a lot of our patients with COPD coming right out of the hospital, they had a hard time tolerating their PT visits and they were starting to cancel. And it's hard to get somebody better if they can't participate. So I had to problem solve. I knew a speech therapist in Florida that worked in a skilled nursing that used the breather. She used the breath support. She did a lot of work with the cardiopulmonary patients. So I consulted with her, brought her on PRN, and we were able to put in the speech therapist first. And they were able to work on their breath support, work on their endurance, and then they were able just in a couple weeks to tolerate their physical therapy and their occupational therapy. And it really was amazing. Those patients taught me what they needed. You know, by saying, I can't do this, we had to problem solve. And it was really neat to see the breather in action and the respiratory muscle training. I learned a lot from the actual patients.
Thank you so much, Wendy, for sharing your clinical experience with us. That is amazing. What we like to do now is to introduce you to our general protocol, which you see summarized here on this slide. But I'm not really going to go into this because I think the best way to do this is by just showing you one of our training videos. You can find these on our website.
Here's a quick recap of the breather protocol. Using the breather, you do 2 sets of 10 breaths, twice a day, 6 days per week, for 4 weeks. Record your results in the training journal or in the Breather Coach app. Your resistance settings for the breather should be at a level so that you can do the set of 10 reps and then possibly do 2 to 3 more reps if you had to. Secure the mouthpiece with your lips, not your teeth. Sit or stand upright, place one hand on your stomach, and take a forceful inhale through your breather. You should feel your fingertips move apart as your stomach expands. Hold for a second and breathe out. Using the breather, you do 2 sets of 10 breaths, twice a day, 6 days per week, for 4 weeks. Record your results in the training journal or in the Breather Coach app. Your resistance settings for the breather should be at a level so that you can do the set of 10 reps and then possibly do 2 to 3 more reps if you had to. Secure the mouthpiece with your lips, not your teeth. Sit or stand upright, place one hand on your stomach, and take a forceful inhale through your breather. You should feel your fingertips move apart as your stomach expands. Hold for a second and breathe out. You should hear a distinct wind sound. Make sure don't puff your cheeks or use your chest or shoulders. The ideal setting of your resistance dials should make your breathing muscles work at about 60% of their maximum effort. What you're going for here is 10 reps of somewhat hard effort using your breather. Remember, 2 sets of 10 reps, twice a day, 6 days per week.
So that was a really good and quick introduction how to use the breather. What you saw in the video is that it's a really good idea to monitor your training sessions just so that you can see the progress and monitor your adherence. So what you see here is the training journal, where the therapist determines the optimal training protocol and the patient or the user then notes down whether or not the sessions were completed, what the settings were for inhale and exhale, and how it felt. It's also a good idea to add some simple outcomes that are assessed before starting respiratory muscle training and again after about 4 weeks. So the outcomes, of course, always depend on the underlying indication for respiratory muscle training. So while the 6-minute walk test and perception of dyspnea would be a good assessment for a COPD patient, for example, improvements of dysphagia would be better monitored by the food oral intake scale or penetration aspiration score, for example. The important thought here is for both the therapist and the patient to see how respiratory muscle training benefits the user.
Thank you so much. I've chosen a few of the questions that have come in so far. And let's start with, has the breather been used in clinical trials?
I'm happy to answer that. So yes, the breather has been investigated in several clinical trials, as well in a range of pilot studies. To just kind of give you an idea of the outcomes that were observed, I can give you some numbers. For example, a clinical study in COPD patients showed that 2 weeks of respiratory muscle training using the breather increased maximum inspiratory pressure by 31% and the 6-minute walk distance by 55 feet. Another example is in a case study, a patient with spinal cord injury used the breather for 6 weeks and improved his maximum inspiratory pressure by 113% and his maximum expiratory pressure by 117% and his peak cough flow by 67%. And that kind of resolved his main problems, which were an unresolved cough. In a home health setting, what we could show with the breather is that 4 weeks of respiratory muscle training led to a 92% increase in peak expiratory flow and 116% increase in maximum phonation time in COPD patients. Additional studies using the breather have shown, for example, that the breather nicely activates higher laryngeal muscles, and that has been shown by surface EMG. And that's a really important point for using the breather with dysphagia patients. Also, you have seen that in the video. We also have an athlete's version of the breather Fit, and that has been tested by the military, where it dramatically increased selection rate for the special forces recruitment. And also several other studies are currently in the pipeline, and that includes a study in the LVAD patient population that is done at the Mayo Clinic at the moment. They're currently recruiting patients, so we're eagerly awaiting those outcomes. And I'll stop here to respect everyone's time. But that was a really good question. Thank you.
Question: can respiratory muscle weakness be determined without using a manometer?
Well, a bona fide diagnosis of respiratory muscle weakness cannot be confirmed without establishing mid-band map really using a manometer. But the underlying diagnosis, kind of patient history, present symptoms can give you a good indication whether respiratory muscle weakness may be present. Dyspnea and exercise intolerance are, for example, good indicators for respiratory muscle weakness, and then additional symptoms such as fatigue and reduced health-related quality of life may also imply the presence of respiratory muscle weakness. But yeah, Dr. Aldarondo may probably want to elaborate on that.
Thank you, Nina. As you may recall, from a few slides back, we talked about the prevalence of respiratory muscle weakness. So whether you like to admit or not, it is all over us. And it just takes a little bit of extra interest and awareness to recognize the fact that it's really present more often than not, depending on what environment or the acuity level or patient population you're dealing with. And obviously we cannot establish the respiratory muscle weakness without measurement of the MIP-MEP, but as we talked about, is very common. And what I can tell you is, if you have a patient who has obvious sarcopenia, cachectic patient, who is very debilitated, that patient in all likelihood would have some degree of respiratory muscle weakness or dysfunction. If the patient has also evidence of increased respiratory muscle work, that patient will have some degree of respiratory muscle weakness, and that patient will be prone to develop respiratory fatigue, which basically is the indicator of a dysfunctional bellow system, that the patient symptom level is such it markedly increased before even completing the task at hand. So you can actually, when you see these things, when you have this, say the proper phenotype of patient looking at, and you observe those findings, you can anticipate the patient will have, and it should not be a deterrent. It's such a safe intervention that it should not be something you need to wait for a manometry to be done to confirm your MIP-MEP to actually initiate treatment. You can actually do so, and when appropriate, when available, you can then subsequently do your further assessment. I hope that answers the question. It's a very good question, by the way. Thank you.
Yes, thank you. The next one is respiratory muscle training suitable for people with comorbidities?
I would say yes, especially if the comorbidities may also be associated with respiratory muscle weakness, which is often the case. Because, for example, 64% of COPD patients also have heart failure. And respiratory muscle training here offers really a holistic approach that may provide benefits for the comorbidities as well as for the primary diagnosis. But Dr. Aldarondo may probably add to this from some practical examples.
Well, thank you. Actually, I like the holistic approach, by the way. As you can intimate from what we talked about before, it'll be very often, probably more often than not, that you will be dealing with more than one morbidity in which that is contributing to respiratory muscle dysfunction or weakness. So you may have a patient with COPD who also has heart failure. They overlap, happens all the time. We have a patient with COPD who had a stroke. He also has upper airway dysfunction and is experiencing glottic dysfunction as well. Or the patient with neuromuscular disease, myasthenia patient or spinal cord injury, who may have heart failure as well. And by the way, a lot of these patients eventually develop debility, generalized debility, even furthermore, if they get an acute event, end up in the ICU. So the fact is that, let them come. If you have multiple comorbidities, it is actually another indicator to be more proactive with respiratory muscle training and not a deterrent. Very, very, very few times, if any, there will be a reason for not employing or initiating respiratory muscle weakness because there's a comorbidity. With the exception, though, of the high acuity setting of somebody who is obviously severely decompensated heart failure or a severe COPD exacerbation, that is not the moment to initiate respiratory muscle training. You stabilize the patient, then you do so. But bearing that aside, the comorbidities, if anything, is another reason to initiate. So thank you for the question, though.
The next one's a pretty good question. How do I determine the correct intensity or setting on the breather?
Yeah, that is a good question. And it's a very important question. So the intensity, it always depends on the training protocol, and that is, of course, guided by the underlying condition. And that should also always be discussed with your clinician, of course. And once the intensity is set according to your condition and your baseline muscle strength, it's really important that you check whether you hit the set target intensity. And the best way to do this is to put a manometer in series with the breather when you do that for the first time, if you have the opportunity. But also with a bit of experience, you really develop a feeling of whether you're working at the target intensity or not. And if you feel that the intensity is getting lower, then you can increase the settings. But if you need more information and guidance on the intensity, please again go to our website. We have more material there.
My experience has been that as the patients get more adept and confident, and they're much better about sensing their degree of intensity and so forth, and their performance increases very satisfactorily. Thank you for the question.
Okay, let's do one more. What is the difference between resistive and threshold devices?
Yeah, that is a really good question, which we get quite often, really. And that is because there are actually quite a few threshold devices on the market. And in a threshold device, you have to overcome an initial pressure or initial resistance to pop open a valve. And that's set at the target pressure. And once the valve is opened, there's no resistance to the airflow anymore. So the difference to resistive devices like the breather is that here, the resistance that your muscles are working against remains constant throughout the entire breath cycle. So your inspiratory and your expiratory muscles are working for the entire 2 to 3 seconds during inhale and for the 2 to 3 seconds during the exhale. So this puts kind of a more sustained workload on the muscle. And that was also shown really nicely in a study commissioned by Dr. Watts of the Christian University in Texas in 2019, actually this year. He confirmed a nice and strong muscle activation. He showed this by using surface EMG during both the inspiration and the expiration through the breather. Other evidence has shown a direct comparison between the two methods, that the threshold and the resistive devices both strengthen respiratory muscles. But that the curve of activation looks different, confirming that the sustained muscle activation that you get with the resistive devices, such as the breather.
Well, I scrolled down and I see lots more questions. So let's continue with a few more. But before we get to those few more questions, really good questions, you all. Great job. Here's what we'll do. The ones that we didn't get to and the ones we didn't get to answer, we'll make a top 10 list and send that out on Friday, and we'll email the responses to you so you'll get all the questions and answers. And that way we can still, get everybody out of here tonight on time. So we'll get a few more answered, but we'll make sure that we send out that top 10 list to you as well. And after the questions, we'll briefly share upcoming episodes with you. I want to make sure that you see some little teasers on what you're going to see next month. And we'll conclude with an offer to you all. The first 50 people who sign up will get a free one-on-one meeting with one of our clinicians. And this is a very valuable thing to have that one-on-one time where you can ask more questions. You can have that extra support. Maybe you just started using respiratory muscle training. So I'll give you information on that at the end as well. So what should be our next question?
Can I pick Wendy? I saw a really interesting one in the chat. Somebody asked about whether the breather can be used in the pediatric population in children. Yes, it can be used. There are really good use cases for children, especially children with asthma, but also with other respiratory problems. If you use the breather or if you do RMT in children, there are, of course, some special considerations. So one of them is children, of course, have lower respiratory muscle strength, and that is age dependent, sex dependent, as well as weight dependent. And we created a specific landing page for that, so where you can look up kind of what pressures you should be working with to make sure that you're safe. The other consideration is that if you do RMT in younger children, the mouthpiece, the main mouthpiece, might actually be a little bit too big. So what we have heard is really useful there is to use the smaller mouthpiece that comes with the breather. That's more suitable for the small mouth of children. But there's some really nice studies that have shown that using RMT in children reduces the frequency of asthma attacks, for example, and as well as the symptoms during the day as well as during the night. So it does really help. Another question that we got that I would like to answer, that was more of a personal one, but I think that may be of interest to many of you, whether RMT is useful when you have sleep apnea. Absolutely. There have been some very nice studies that actually came out of Australia from Jennifer Rainish, and she has shown that doing RMT improves the quantity and the quality of your sleep. It also reduces the frequency of awakenings at night, limb movements, and arousal into the lighter stages of sleep. So it is very useful for sleep apnea. We have had many patients saying that using the breather actually led them to reducing the CPAP a little bit. So it is really recommended for people with sleep apnea. Other questions that we've had was, how does the breather compare to a PEP device? This is also something that, if you're interested in this, we can send you some material with more specific specifications of how they compare. But in general, most PEP devices on the market have very little resistance. So the expiratory muscle training that you get with them is typically much lower than you would get from the breather. And of course, because the breather is an inspiratory and expiratory muscle trainer, you're training both parts of the breath cycle. So you get the double effect of improving your inspiratory as well as your expiratory muscle strength. And the effort question, I think we've answered. The last question I would probably just want to touch on is whether you need a prescription to order the breather. You don't need one. No, anybody can order that. It can be ordered via our website directly. It can, of course, also be ordered by other online market stores. That is possible, where it may be a bit cheaper, but that's on the side. So no, you don't need a prescription. However, if you're an inpatient and you get a prescription, it might be easier to get the breather. And I think that, yeah, I think that covered most of the questions.
And like I said, we'll make sure that we get to these other questions, like the contraindications, things like that. I see a lot of good questions. The billable service. The breather is a tool like weights for arms and legs. So therapists that I work with definitely bill it as the exercise or bill what they are treating. So it's a tool that they use. So there's different ways to go about that depending on your setting as well. So we can try to get more information on those questions for you. So over the next few months in our Improving Patient Outcomes series, we'll focus on assessments, evaluative tools. We're going to get to a lot of these topics that you all have brought up, patient case studies, expert roundtables on controversial, maybe, a lot of informative topics, things that matter to clinicians most. And if you have suggestions for topics, we're going to use some of these from your questions as well. But if you have topic one-liners you want to throw into the chat right now, that would be great, because we are going to take those. We're going to use the information we get from you, the audience, and make sure we target each month topics that matter to you most. So you can use the chat for that as well. We're going to definitely take information from there. Now I want to take a moment now to show you a sneak peek of one of the assessments that you might see next month.
Now I'm going to check your breath support while you're talking. I'm going to tap my pen, and I want you to count out loud to 15 with each tap of my pen.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15.
Great. You only stopped once to take a breath. That means you're a level 1 on the ventilatory response index.
A little sample of one of our upcoming webinars. We also will be focusing on, we've received a lot of emails about PDPM and the October changes, and especially using the breather in group settings. That's something that companies are looking for new ideas for the group and concurrent, and the breather is a great focus for that. So we're going to have a lot of that for our next month, and I wanted to give you just a little sneak peek. Now, in conclusion, let's see who wants to secure a free one-on-one session with one of our clinicians. Once the webinar ends, your browser window should take you directly to a page that looks like this screen that I have up. You'll be able to select from various times and days to book a free one-on-one call with one of our clinicians. This way you can choose a time that works for you and ask those specific questions about a specific case that you're working on, or maybe, like I said, you're brand new and you just want that extra layer of support. This is a valuable bonus from today's webinar, so make sure you take advantage and pick a time that works for you. Thanks again for joining us today. We truly hope that you have learned something new related to respiratory muscle weakness and respiratory muscle training, and you'll take this new knowledge and apply it to your practice. And from all of us at PN Medical, go make a difference, and goodbye.